We're here today to look at cardiovascular disease and how hormonal therapy influences that. And the question, of course, is why look at cardiovascular disease? What's the data that would have us concerned, and why would I be asking Dr. Gupta to really weigh in on several of my patients when we start hormonal therapy? Well, it's interesting to note that as patients get older, there is a higher risk of cardiovascular disease. It's a common cause of death in men with prostate cancer. We do know that LHRH agonists, such as leuprolide, for example, has been linked to a higher cardiovascular mortality and morbidity based on several papers, many of which have been largely retrospective and have not really been based on randomized clinical trials. Nevertheless, the data is very much in the direction of suggesting that there is an adverse effect of these agents on the cardiovascular system. It starts off very early. We can see it usually within the first year of treatment. Therefore, if a patient comes in who has prostate cancer, metastatic, localized, makes no difference. The fact that pre-existing cardiovascular disease is present may in fact put this person at a greater risk of other events. And therefore, it's extremely important that we have a multidisciplinary care coordination of the patient who has this. What's very important as well is recognizing very early on that it's not the oncologist's job just to monitor blood pressure. We need to get the internist, the primary care physician, the cardiologist involved, particularly in these patients who have high risk. Now, the incidence of cardiovascular disease in men, as I've mentioned before, in prostate cancer is high. And if you look at the panel on your left, which shows on the y-axis the age-specific incidence per 100,000 people, these are men with prostate cancer. As you can see, peak age for diagnosis is roughly between 70 to 79. On the right, you can see the cardiovascular events, and if you look at the very light blue, and you can look at on the x-axis, the ages, 40 to 49, 50 to 59, 60 to 69, and the like, those patients in the light blue represent all patients who have some form of cardiovascular disease. And you can see, certainly if anybody reaches the 90 to 95 year interval, that their risk of cardiovascular disease is substantially higher. But more importantly, if you look at the darker blue, there is a representation of major cardiovascular events, they being defined as myocardial infarction, stroke, or death due to any form of cardiovascular disease, either alone or following complications of coronary revascularization. But the point is, it really goes up significantly over time. So this is an area which is extremely important in recognizing the potential for adverse events. As mentioned, it's the second leading cause of death in men with prostate cancer, and my point here is really to show you that as early as probably the early 2000s, two studies that were looking at the effects of intermittent hormonal therapy discovered something very unusual, and that was that patients developed an increased risk of had increased risk of cardiovascular events. On your left, you can see the EORTC, European Organization for the Research and Treatment of Cancer, based on a trial of intermittent hormonal therapy. They actually found that patients had improved quality of life and improved survival with intermittent hormonal therapy, as opposed to patients who were on continuous hormonal therapy. But if you notice in that pie chart, the risk of cardiovascular disease was as high as 34% in those patients who were on continuous androgen deprivation therapy. Similarly, the Southern European Urology Group in Europe showed something equally of interest, and that is, again, intermittent androgen deprivation therapy, but with the caveat that they didn't seem to see a difference between improvement in survival, whether you were on continuous androgen deprivation therapy or intermittent androgen deprivation therapy. But again, for those patients who were on continuous, you'll notice cardiovascular disease was 27%, so higher than would have been anticipated.